talk. So thank you, Dr. Fletcher, for joining us today to do our Grand Rounds talk. I'll just introduce Dr. Fletcher. You all know Dr. Fletcher, but she went to University of California, Santa Barbara for undergraduate and attended USUS for medical school. She did her family medicine residency at Travis Air Force Base and OB fellowship at the Santa Clara Valley Medical Center. And Dr. Fletcher spent 14 years as active duty in the Air Force, was faculty at Offutt Air Force Base, and the medical director at the Ramstein Air Force Base. And she's currently at Kaiser Permanente in Northern California. She's been there since late 2018, and she practices full spectrum family medicine, including surgical OB. And she's also IMA in our department here at USUS. And one interesting fact, if you didn't know, Dr. Fletcher created the RESET program, the Reward Efficiency, Set Priorities, and Empower Teams program. I encourage you to read more about this program in her bio. With that, I will hand it over to Dr. Fletcher. She is okay with everyone asking questions as we go along, so you feel free to raise your hand if you want to ask question. So if you go to the reactions button, there is a way to raise your hand, or you can put your questions in the chat and I will monitor that. Thank you. And Dr. Fletcher, the floor is yours.
Thank you so much. I'm excited to be here. If you're able to, I would love for at least a few of you to turn your video on, because as you guys all know who have given virtual talks, it's so strange to stare at a blank screen. So come join me with your beautiful faces. Thank you. Okay, so when I was thinking about what to do this talk on, I was thinking, what would I want after this crazy couple of years? What would be like helpful? And I think that what we're going to try and do today is, unlike most talks that I do where I love like fleshing out one kind of full idea, and we're going to do like just a rapid fire quick hits of like everything you missed while your head was buried in all that is COVID. So, you know, actually there was a lot of studies that were published while we were all buried with COVID and things that came out. And I think a lot of it sort of got lost in that shuffle. So we are going to dive into a bunch of quick hits for you. And hopefully, you know, it'll be kind of like get you, you know, caught up in your women's health sort of quick hits so that you can just start fresh from here. At the end of the talk, we're going to talk a little bit about how to stay on top of things. That's something I have an interest in, because I feel like I have some cheats that I want to share with you that just make it easy for me to feel like I'm up to date, but I'm really not someone that's reading all the time. So, okay, I have no financial disclosures. And of course, all these views and opinions are mine. Okay, so let me see how I can move you guys across to the top of my screen real quick so that I can see. There we go. Okay, so first thing we're going to do is look at some of the latest clinical concepts in primary care, but definitely an emphasis in maternal health. There were definitely a few key guideline changes that we're going to take a closer look at. And then something that I'm very interested in and is becoming much more discussed in the literature is this role of affordability and the impact that affordability and sort of fiscal responsibility is starting to play in medical recommendations. And then again, hopefully we'll share, and hopefully we'll all kind of share with each other some efficiency hacks for staying on top of, you know, what is a completely overwhelming amount of literature that comes out. Okay, so first quick hit for you is in regards to PID. So you guys probably are aware that, you know, standard treatment that we've done for outpatients with mild to moderate PID is usually ceftriaxone and doxy. And a trial, I'm trying to remember where this trial came out of, UCLA, looked at 233 women with PID, and they were all treated with the standard regimen, and then one arm was treated with an additional Flagyl BID. And they showed better results at 30 days for the group that had Flagyl added. And so the recommendation now for mild to moderate PID is going to be ceftriaxone, doxy, and the addition of Flagyl. I think some of us were kind of doing this, but it really wasn't standard. And now this is going to be the standard recommendation, is to do all 3 of those treatments. At 3 days, their treatments were similar. Their clinical cure rates, however, were better with the Flagyl arm, with a 96% 14-day cure rate versus 90%. So add some Flagyl. All right. And Winnie's monitoring the chat because I can't see it, but I'm really comfortable with you guys like completely stopping. I think there's not so many of us that we can't just have a conversation. So please feel free to interrupt me. Okay, next thing, single dose treatment for gonorrhea. So in January of this year, the CDC updated their guidance for the treatment of gonococcal infection. And this was really out of recognition that there was decreasing susceptibility to azithro for gonorrhea. So now the recommendation is a single 500 milligram IM dose and 1 gram for patients greater than 150 kilos. And this higher dose of ceftriaxone is helpful for some of the isolates that have a higher MIC. Additionally, just like we normally would, you would add doxy presumptively if chlamydia was not ruled out. However, if you had ruled out chlamydia, then you would only treat with the single 500 milligram IM dose. Previously, we were doing 250. There's even some older recommendations that did 150 for the dose. So big dose for gonorrhea. Okay, chronic pelvic pain, kind of staying in a little bit of the same lane here. I don't know how many of you guys treat chronic pelvic pain. It's, I think my practice sort of tends to have a large portion of patients in this lane. And there are really limited treatment options for pelvic pain. So anytime something comes out that shows, something, it's nice to have it. This was a little bit of a disappointing study looking at gabapentin, which has become much more widely used for chronic pelvic pain, along with everything else. I don't know if you guys have noticed, like gabapentin, man, it's like having a heyday right now. So this was a multi-site trial out of the UK with 300 patients with chronic pelvic pain, and they were given gabapentin versus placebo. Really, they had their worst and average pain scores were similar. The adverse effects, however, were much higher in the gabapentin group, with dizziness and fatigue being more common. The study had some limitations, and so most centers are still recommending gabapentin. I know I still actively use it for chronic pelvic pain, but I think this was something for us to pay a little bit of attention to. I'm actually noticing significant side effects with gabapentin. I think the more I'm using it for lots of different things. So I think just, giving patients appropriate expectations for that. And then again, just remembering that with chronic pelvic pain, we're going to want to use our, multimodal approach with, pelvic floor physical therapy, biofeedback, group therapy, cognitive behavioral therapy, and then aggressive lifestyle measures. Okay, so let's flip over to a little bit of OB stuff. So delayed cord clamping. So this is, where we wait 30 to 60 seconds after the baby is delivered before clamping the cord. And this is known to facilitate some transition for the fetal to newborn life and improve decreased rates of anemia and so forth. And one thing that was, especially when I was training, that we often did, especially with preterm infants or at the time of section, if things were done for more urgent reasons, is that we wouldn't, it is kind of, I gotta say, especially in a section when you're sitting there and, your hysterotomy is bleeding like crazy and you're waiting 60 seconds, it's kind of a long 60 seconds. So a lot of us would do cord milking, and you guys have probably done or seen this where you kind of just like milk the cord down, thinking, that you're facilitating faster transfusion to the baby. And there was a lot that came out kind of in 2016, 17, where this practice was starting to be frowned upon because there were some studies that had shown that perhaps this was increasing your rate of grade 3 intraventricular hemorrhages. And this newer study that just came out in April was a large meta-analysis, and it actually showed low and similar odds for severe IVH with both delayed cord clamping and cord milking. I think the consensus will remain that delayed cord clamping is preferred and more physiologic, But I do think that most of us are going to probably resume cord milking with preterm infants or when resuscitation is rapidly needed to facilitate that transfusion. So that was kind of a nice thing to see and kind of reinforced behaviors from before. I think this really just illustrates, I'm so grateful for people that do this research, I got to say, because it's just fascinating as I was preparing for this talk and looking at so many things that people take another look at. We think we've closed the chapter on something, and my brain tends to think that way, like, oh, okay, that's the answer. I love that people are still curious and then look again and find different results for us to consider. Okay, so let's talk about penicillin allergy, especially, in the OB world, this is a big deal. And really, the labeling of a penicillin allergy is widely known to increase morbidity and hospital utilization, and really across specialties. And this is, because when you're making choices for, peripartum antibiotics or preoperative or postoperative antibiotics, when someone has a penicillin allergy, you're very limited, and you're often needing to choose either sort of an inferior antibiotic choice or antibiotics that are kind of bigger guns, increased risk of resistance, as well as increased side effects. So there is a push in the non-obstetric world of delabeling patients with penicillin allergy. And what we're seeing here in this study, and also just sort of in the literature in general and in the recommendations, this one was it was published in April, is this push to delabel even pregnant patients with penicillin allergy. So this was the largest study to date that looked at this. They took 222 patients, and the OBs referred them for an allergy evaluation if they reported a penicillin reaction that was more than 5 years ago. And these included very IgE mediated sounding reactions, as well as things that did not sound like an IgE mediated reaction. So it's kind of all comers with this penicillin allergy on their chart, and I know you guys all know what I'm talking about. And what they saw was that there were no serious reactions, no fetal or maternal complications with that. And then 94% of those patients had their penicillin allergy removed. So ACOG wisely now supports that you do penicillin allergy testing for pregnant patients that report a penicillin allergy. I think what we'll see come out of this, I'm trying to remember how, I think there was quite a variety of gestational ages. I think we'll see some more guidance on when, best gestational ages to do this. I would encourage, in my own practice, I try to limit what I'm doing in the first trimester, not because it likely makes a difference, but just because complication rates in general are higher. And it's just, I think, easier on patients when they don't have other confounders that make them wonder what possibly happened, if that makes sense. So I try to kind of less is more in the first trimester. All right, hopefully you guys are hanging with me here. I know this is fast and furious. We're gonna get to some fun stuff too though. Okay, gestational diabetes. Many of you have probably heard of the one-step approach for diagnosis of GDM, which many of us have not liked. And now, based on this trial, yay, it goes back to a two-step. This came out in March of this year. And this previous meta-analysis had found that one-step diagnosis of GDM, which I don't know if you guys are familiar, but the two-step approach is probably what you're more familiar with, where it's a 50-gram load for the first step. And then when patients screen positive, then they have a 100-gram 3-hour test. So it's kind of that initial test, and then the people that screen in go on to do the second step. The one-step approach was a 75-gram 2-hour GTT. Did require a night of fasting, an overnight fast before doing it. But I think what most of us didn't like about it, because I mean, one step sounds nice, is that it captured, I mean, it caught so many people. And that's what this March trial sort of teased out, was that really, and it was very large, 23,000 pregnancies. And they saw that the one-step test resulted in more patients diagnosed, 16.5% versus 8.5%, but no improvement in pregnancy outcomes. And they looked at several different endpoints, but what we're probably most interested in is LGA and preeclampsia. So we shall continue with the two-step approach, which is nice because the one-step approach was kind of doubling our GDM numbers. And as you know, This becomes the slippery slope of, intervention with obstetrics, often, inductions. And, I think that sometimes we do more harm than good. Oh, it just told me somebody raised their hand. Let's see how, I think you can just unmute yourself, but let me figure out how to get it so I can see you.
Hi,
Okay.
it's probably me, Lisa Harris.
Hi.
I'm in the car. I don't have my video on.
Oh, no worries.
With this particular study, that they assessed for rate of compliance of completion of test, because I could imagine in certain populations where they may not be as dependable to complete the second step. I'd rather them be diagnosed than have a misdiagnosis.
Yes, for sure. And we sort of use that same thought process for sure in our patients that screen in and then don't follow up with the 3-hour. We'll manage them as though they screened positive. But I am not sure if they looked at that. I think that brings up an excellent point, though, that a lot of times in these trials, we're seeing sort of the best case example of the very hands-on approach, physicians knowing they're being watched in a trial and also patients knowing that they're being watched. So I think that's a really good point of, compliance needing to be something that we consider. So certainly, I think if you have that patient that, you're concerned about compliance, then, I think a 1-step would be completely reasonable to do. And I also think that if you have someone that screens in on the first step of a 2-step, it's reasonable to monitor them, checking sugars. A lot of times, though, unfortunately, patients that are not compliant with the testing are also not compliant with their sugars and their antenatal screening. So it's a tough situation for sure. Thank you. Okay, so let's see here. Let's go over to some, these studies are always so difficult. I'm like old enough now, which is crazy. I still feel like I'm young, but now I'm like, realizing I'm seeing things come and go. Like my, all my staff used to tell me they saw. And so oxygen use in labor has now come and has now gone. I'm not sure how familiar you guys were this. This has been a long time coming, but this was a meta-analysis that came out in February that really sort of put this more, much more definitive that there really is increasing evidence that there is no clinical benefit to using oxygen in labor. There's really no benefit, maternal or fetal, but definitely they're seeing no benefit in fetal heart rate abnormalities and acidemia at birth. So this basically compared oxygen supplementation to room air, and again, looked at umbilical artery pHs. So it's always still weird for us because, I come, running in the room for a big D cell, and you can just feel all of us in the room are like, it's just so normal to want to put oxygen on. And, it's not been benefiting us. So I always laugh, though. I remember this this patient that I had when I was in fellowship, and she was 17 or 18, young and just rocking her labor. But when she would push, I think she had this very big placebo effect of the oxygen, like giving her superpowers to push. And so in between every push, she'd be like, oxygen, oxygen. We'd rush over, give her oxygen, take a few hits, get back at it. So I would say it had lots of benefit for her, but there you go. Okay. And, Mike, what you got?
Oh, sorry. I was just wondering, did they look at because the problem with the fetal pH is that assumes that you delivered them right then. And if you delivered them right then you wouldn't need the oxygen. Because the only other thing you can do is flip them around, right? Is there any harm of oxygen? Because I'm with you. All my patients feel like athletes on the sidelines getting set for their next round of contractions.
Right. There was so I would need to dig into the harm thing a little bit. I would need to dig into the neonatal literature. There is some, in general, in the neonatal literature, there is increasing evidence of harm in resuscitating babies with oxygen for sure versus room air, even with, room air with PPV. But I haven't seen that there's any harm with maternal oxygen supplementation. And this made no reference to any harm with that. I think that what the harm could be, if I extrapolate and just give my opinion a little bit, is that by taking an action that you think is helpful that isn't, I think you could be delaying care. And so, you know, there's still a
Because
lot
you're
that you
waiting
can
for the
do.
effect.
Yeah, because you're like, okay, now we're treating this, but you really aren't. But there is still a lot you can do. I mean, you can move moms around, you can start a fluid bolus, you can turn your pit off. You know, there are things that you can do to manage that. But I think it's more of like not to be lulled into this, you know, I'm doing something. And then also just practically speaking, most women, not my 17-year-old that wanted her oxygen hit, but most women, it's a huge pain to keep the mask on. And to, you know, don't even get me started with the whole oxygen and COVID thing. That was, you know, a whole fun thing in the labor room for a bit there. But yeah, so I think, you know, it's more that there would be those situations where mom wanted it off and nurses were saying they needed to keep it on. And so I think it's just something to have in the back of our mind, likely not harmful, but really not going to be our go-to. But yeah.
Thank you.
Okay. Thank you, Mike. Okay, let's go on to the ARRIVE trial. So I don't know, I don't even know how many of you guys do obstetrics, but the ARRIVE trial came out, oh gosh, it's been a while, but now what's happening is there's a bunch of secondary analyses going on. The ARRIVE trial looked at the benefits of induction of labor at 39 weeks versus expectant management. And rather surprisingly, showed a, a decreased rate of C-sections in the induction group. So it was 19% versus 22%. And some people have broken that down to, with taking out some variables, to more of a 19 versus 26%. Interestingly, that's like lower than the baseline C-section rate known for NOLIPs. These were all nulliparous women with uncomplicated pregnancies. And I think that highlights Lisa's point where, you know, what we're seeing is that when you have a group of people that are sort of being watched in a study, I think all the I's are dotted, T's are crossed, protocols are followed, this sort of thing, because the C-section rate in general across the study was lower than one would expect. And what the original ARRIVE trial showed is that basically for every 28 women that you induced electively at 39 weeks that fit this criteria, that you would, you know, prevent one C-section with no adverse outcomes. Showed longer time in labor for these women. Obviously you're inducing them and ripening them. So it showed a longer time in labor, but overall a shorter hospitalization. So it really has kind of thrown, it's thrown us all for a loop a little bit, and the guidelines are very guarded. As you guys probably remember, we had just got moved like totally away from inductions, right? From elective inductions. You know, this is where, you know, we entered this era of like, you know, practical, like chief of the hospital approval for anything less than 39 weeks kind of a thing. And now maybe we're swinging back to at least like a 39-week elective induction. There's a lot of ramifications with this though, because staffing, the duration of time for ripening, how itchy we get to deliver people, you know, when you're used to having certain people there for a certain amount of time, but now you're taking all these people that have like no labor symptoms whatsoever, nulliparous women with rock hard cervices, and getting them to deliver it seems a little bit daunting from a staffing perspective. So I think the cost effectiveness and the staffing implications are where we need to get some more analysis done. It also, in one of these secondary analyses, showed, again, this push towards routine and early amniotomy, which, yeah, it's fun. I mean, I love my job here. I supervise midwives. So we always take call as a pair. And, you know, so I really like to give them autonomy. But it's these things that, you know, often highlights kind of where we all have been trained differently. And so this is like, you know, this is a fun study to sort of, you know, hash out together, because I think there's, you know, I love the perspective that my midwife's bringing of this whole other side of things as far as, you know, mom's expectations and the experience and all this stuff that I think sometimes when we get into these trials and, you know, pit, and let's do 6x6 pit protocols and all this, we sort of sometimes forget that. So I like that they ground me back. So more to come. There will be lots coming out and people trying to replicate the ARRIVE trial for sure. Okay, let me see if I can get, there we go. Okay. I feel like I saw Dr. Ramey on here, but I'm not sure. Oh yeah, I think he is. Anyway, every time I read about cardiovascular stuff, I always think of Dr. Ramey. So a shout out for you, sir. So cardiovascular risk to offspring. This was looking at a study. This came out in March, looking at cardiovascular risk to offspring. So do cardiovascular metrics like BMI, blood pressure, lipids, glucose, smoking during pregnancy affect baby? I think all of us are like, well, yeah. So this looked at 2,300 mom-baby pairs and associated the cardiovascular profiles at 28 weeks, and then compared it to the cardiovascular metrics of the offspring at age 10 and age 14, and showed that poorer profiles in moms at 28 weeks were associated with poorer metrics in these children. Again, I think just emphasizing that we need to optimize cardiovascular health in moms, and that potentially that could benefit the cardiovascular health in the offspring. It's likely that this whole field is going to balloon as we understand better the epigenetic modifications that happen in utero and the like transgenerational inheritance of those patterns, and looking at how do we modify preconception counseling? Does optimizing cardiovascular metrics prior to conception or perhaps even during the pregnancy impact the health of the offspring or babies? So interesting stuff. Okay, so GBS screening, this one kind of also bridges in a little bit to the concept of affordability, which we'll talk about in a few minutes too. So many of us have seen two strategies for GBS. You may not have even really noticed the switch, but the screening sort of shifted from screening at 35 weeks to 37 weeks, even it really kind of 36 to 38, like 37 and 6. And then always rescreening women with an expired GBS, which is 5 weeks after the original testing. This study from April of 2020 confirmed that the 2019 guidelines resulted in the same cases and of neonatal death and an overall decreased healthcare expenditure of $73 million for the US. And interesting, they compared to if we had no screening or prevention strategies in place, that the overall savings of just a GBS screening program in general is 1.26 billion, which I was quite impressed with. I'm trying to see if there's anything else interesting about this. Yeah, and so it was not statistically significant, but there actually appeared to be fewer cases of neonatal death in the 2019 guideline arm, analyses, but not statistically significant. And doesn't totally make sense that there would be less, but I think reinforces that us screening later is fine, and we're saving lots of money with not rescreening women, and that in general GBS screening is something that we should continue doing. I think some of you may have seen this. I have not been at a center that has it yet, but there is some rapid GBS screening that is developed and being utilized and trialed that would allow for real-time GBS results at the time of arrival to labor and delivery. So that would be very cool. Okay, so let's move over to some topics that are starting to be really interesting, and I think we're going to see tons more, and I think there's tons of work to do. And this is on a lot of healthcare for transgender patients. And really, there's quite a bit of literature on transgender health and healthcare and sensitivities and things like that. But now I think we're starting to get into a little bit more of the just challenges and things to think about. So this study in April, I believe, February, was a retrospective review looking at the risk of clot. And so if you think about transgender women that are on estrogen and then undergoing major surgery, could be that they're undergoing gender-based surgery, looking at that, but also some of these patients were just undergoing all kinds of our normal run-of-the-mill major surgeries and on estrogen. And so what do you do with that? Knowing that if you stop the estrogen, it's a pretty quick resumption of menses and masculinization and difficult side effects of coming off of it. And so this was a review that looked at 407 patients in that had their estrogen either continued or held, and actually showed a pretty reassuring low rate of thromboembolism. And the current consensus is to reduce estrogen dose, so not to stop it before surgery, but to reduce it to 1 milligram 3 weeks prior. But I think we'll see more coming out with some of these just interesting situations where you can maybe mitigate risk. And so despite lots of scholarship on this transgender healthcare, there's very little literature on transgender reproduction. And I'm fascinated with this and hope to learn more. This was a study that came out of, in March, it was, UCSF, published in Obstetrics and Gynecology, and looked at, it was a really, I encourage you to read it if you get a chance. It was just a really lovely review of some of the difficulties that transgender men face with trying to achieve pregnancy, and also just some of their thoughts around on pregnancy and on their interpartum and postpartum care. And so many, I think, just recognizing that many transgender men do desire to achieve pregnancy, and there's significant challenges during pregnancy and birth, both related to the isolation that one can feel and the challenges with just society in general, but then also just the hormonal influences and different things of how to manage that. Breastfeeding, often in transgender men, they'll call that chest feeding, and some of the implications for the care, both on labor and delivery and postpartum with nursing and the physicians, as well as just the obstetric care. At Yale and UCSF, they actually have transgender reproductive clinics that are comprehensive with gamete freezing, surrogacy, all sort of options for all of these patients to be able to pursue their desire to biologically reproduce and have children. And interesting, this looked at the men that were still able to conceive while on testosterone. So 20% of the men that they looked at actually conceived while on testosterone, which has been thought to not be possible. That was interesting, and I think something to consider for education purposes, for sure. And yeah, I think there's just a lot of bias and language and different things that we'll all have to explore. I think we're going to see a lot more scholarship on this topic, and I think it'll be really exciting to see that. Okay, so
there was a question.
Yeah, absolutely.
There was a question from Mike if they can continue spironolactone. Is transgender? I think it was referring to the previous slide in terms of surgery. Is that right, Mike? Not sure.
Yes, yeah, with the VTE. So if a patient's on estrogen and spironolactone, I'm assuming the spironolactone is fine.
I would definitely feel fine continuing the spironolactone. I was trying to think through whether or not continuing it in pregnancy, and I feel like maybe it would be stopped and then restarted, but also it would be difficult to achieve a pregnancy on spironolactone. So yeah, I don't know. I don't know about the pregnancy part, but I think for the surgery part, I think it would make sense to continue it.
I don't think it'd be an issue for the pregnancy part because those are transgender men, right? So they wouldn't be on.
Right, they wouldn't be on spironolactone. Yes. Although there's a whole thing about transplanted uteruses now, and there's lots of things, but I digress, or progress, I don't know, but we'll keep going. Okay, so affordability. this is something that I really enjoy learning about and talking about. I think it's the elephant in the room with healthcare. And I'm excited that we, for a lot of my passion and my work with Reset and so forth, it's a lot of us having like more honest conversations together and like being safe together to talk about some of the things we do that we could maybe do differently, or that we're incentivized to do that maybe aren't ideal. And I think that affordability is one of those things that we all need to just talk about. So I think we play more of a role than we think. As you guys know, we have super high costs and really poor outcomes in the United States. Healthcare spending has outpaced the growth of, the economy. We spend more on healthcare as a share of the economy, nearly twice as much as the next highest high-income country, and yet we have the lowest life expectancy. We have the highest chronic disease burden and obesity rate that's 2 times higher than all of the 36 high-income member countries on average. We also have fewer physician visits than most peers in other countries, and thought to maybe be related to this low supply of physicians. And then compared to peer nations, we have the highest number of hospitalizations and avoidable deaths. So, yay, we have work to do. So I like this slide. So if other prices had grown as quickly as healthcare costs, then a dozen eggs would cost, since 1945, a dozen eggs would now cost $55. A gallon of milk would cost $48. And a dozen oranges would cost $134. And this just shows how we compare to these next sort of 10 high income countries. I forget the OECD is, I can get it for you guys. Anyway, it's this collection of grouping these high income countries and looking at their outcomes and healthcare spending. So there we are, just spinning it up there. Here's our life expectancy. So we're like down at the bottom on that one, like the very bottom there. And we rank last on quality, access, efficiency, and equity, as well as infant mortality. So I think a lot of that is not problems for us to solve, in our own little practices. But the Institute of Medicine has estimated that 30% of healthcare spending is going to unnecessary, ineffective, overpriced, and wasteful services. And that is where I think that we can play a role. And in fact, in the Reset program that I'm building for Kaiser, we measure the doctors on affordability, both in a cool risk-adjusted way, but we look at their radiology use, their lab use, their ER utilization, their non-formulary pharmacy, and referral rate. And it's been a fun ride looking at just how to modify these behaviors, like down at the very where the rubber meets the road level. So again, just this idea that these unnecessary tests that we do are really expensive. And then also what I'm trying to dig into more is this understanding that less can be more, not just because it's cheaper and we need our healthcare to be cheaper, but also we hurt people with more testing. And this is something that I think there's no education on the patient side about. I have patients that would just line up, like jumping at the idea to have a surgery. And it's always interesting to me because I feel so differently than that. And I think, oh, that's just because I've seen the bad things, but they're not hearing about these things. But even with just some of our testing, I give my docs here an example of a case where it was like your standard chest x-ray, pulmonary nodule, CT chest, somehow got a slice through part of the liver, thought to see something in the liver, liver MRI, what ended up being a benign lesion in the liver. I don't know if it was like focal nodular hyperplasia or something, and a liver biopsy and a hemorrhage. And so it's like this, slippery slope that we get on. And I think that we think those are rare. And more the literature is showing us that they really aren't rare. So I think a good place to start is for us to just have discussions and start to set guidelines. And I think the USPSTF is starting to do this for sure, as well as other groups, you know, all the groups that are involved with Choosing Wisely, on this idea of, you know, advocating for your patients and helping them to avoid, you know, unnecessary labs, you know, radiology studies, radiation, and getting more evidence-based in our guidelines, but with a notion of those evidence-based guidelines also looking at cost effectiveness and risk. So this is the latest, just a snip, and I'll show you guys later if you're, when we get to it, if you're not familiar with Choosing Wisely, or you don't like often go to it, or you don't have the app, there's kind of, it can be a little overwhelming, but there is sort of one-stop shopping with a place on their site that we can look at. And these are like their top 10 for primary care. I think they have a top 20 for things to just like don't do anymore. You know, they just make a strong recommendation, and they change them sometimes. So there was something in there. In fact, I don't think it's on this screenshot, but it was about inducing people electively at 39 weeks. And now they're like, well, more to come later. So yeah, so they're kind of keeping up with things too. And I think it's, you know, that's part of my hack with staying up to date with things, is to actually tune into groups that I trust that are doing that work for me. This is the Choosing Wisely app that can be a nice way to sort of look at things on the fly. And also to share things like, you know, with residents or med students too. It makes it pretty easy to share things. Okay, so let's switch gears for a few minutes. I wanted to talk about some like just crazy new stuff that's coming.
Can I ask a question, Stacy?
Oh, absolutely.
In terms of the cost effectiveness, you know, I know some of that is kind of liability issues, or, you know, we live in the, you know, litigious
Definitely.
society,
Yes.
or medical legal reasons. People kind of over order tests or do unnecessary treatments kind of to avoid lawsuits and things like that. Is there any, like, in terms of data or what is being said out there?
Yes. So this is something I would love to look at more and be able to really develop a talk on, because it's very interesting to me, because I think that is a lot of what motivates behaviors. And when I have lots of talks with my docs here, that is also sort of an elephant in the room, right? I know that there was one thing that I looked at, and I don't know the details about it, but it did show sort of an increased risk proportional to the number of tests that you order. So I do think that sometimes we perceive more tests is protective, but I think we should open our mind to the idea that in some ways more tests hang you out further, because then there's the follow-up that, and sort of that slippery slope then that has to be followed through on, that introduces all these other places that your judgment can be scrutinized. Whereas if the original test had not been done, then that cascade would not have occurred. So I think what I want to develop is, I think there's probably enough out there to definitively tell people that you think you're protecting yourself, you're not. But I would need to flesh that out. But I think that's where I think that's what I would come up with. And so it would be interesting to look more closely at that. And if I develop that for my folks here, I will definitely share it with you guys too. Lisa, did you have a question? Oh,
yeah.
Hi.
So, hi, Stacy. Thanks for your talk. So my question, the Choosing Wisely, I'm usually on the receiving end of things that I know are not needed with pre-op examination. So I have someone going for cataract surgery, is probably the most common thing, or some other innocuous surgery, and always CBC, Chem 7, this,
it's the
that,
worst.
and
EKG.
And I've pushed back a couple of times, and essentially the answer, and usually only get through to the nurse at the office, is, well, I'm sorry, then your patient can't have the surgery. So it's just, so is anything ever
frustrating,
organizational level about that?
Yeah, I would say that's kind of, you know, and I think the military has this potential of being an integrated model. It's something that I mean, it's actually fascinating how similar our models are between Kaiser and the military. They're massively similar. But I think capitalizing on that integration is something that a lot of people definitely don't have any ability to do. Whereas I think, you know, where you sit and where I sit, we have that, that ability to cross collaborate. I think that using so Choosing Wisely has definitive preoperative testing guidelines that are completely spelled out. And in fact, if you look at the Choosing Wisely ophthalmology guidelines, there's specific recommendations about not doing preoperative testing for cataract surgery in particular. But I think that same recommendation would apply for a lot of different low risk surgical procedures. So, but it's not easy, right? Because a lot of this is like, you know, it's, a lot of it isn't even getting to the physician level. It's like very protocoled. It's like a nurse checking the box. It's anesthesia. You know, it's a lot of like, you know, things that, and sometimes I get it. Like I get when you're trying to keep your head above water in a busy clinic, you know, it's hard. I mean, that's extra minutes that you really don't have. And so, but I appreciate that something like Choosing Wisely is, you know, they've got, I think now like 28 of our societies that are part of Choosing Wisely. I mean, it's becoming like people trying to get on the same sheet of music together. And so hopefully that will propagate more top-down discussion of this in a way that it doesn't have to be such a fight for those that are, you know, that are actually doing the work to sort of, you know, swim upstream against it. But I hear you. It's yeah, definitely a frustrating problem for sure. I think the same could be said with even some of our specialty consults. You know, we have a process of referring people that you use a system that actually tells you kind of what's required before they come, sort of a thing. And, you know, sometimes it's like, you know, the list from like GI of what they want you to order in order for them to see your patient. You know, so what I'm encouraging my folks to do now is like, you know, you are still the doctor. This is your license. This is your practice. So those are recommendations from a specialist, but you're not held to the fire on it. Like, be able to stand on your own 2 feet about what you choose to do, and not, you know, do it at, you know, because somebody's telling you to do it. Do it because it's clinically indicated, and don't ever order a test that you don't know what to do with. So I don't care what they asked you to do. If you don't know quite what to do with copper levels or SPEPs and UPEPs or some of the super weird tests, don't order them. Because like that's coming to you and you're on the line for that. So just don't do it. And if they ask you why, I'm not comfortable. I don't understand how to manage that test. But I think some of that comes down to just, you know, some of that almost pseudo hierarchy that exists between specialty care and family medicine that we need to break through as well. Okay, so let's talk about some fun stuff in our last few minutes here. So one of the things that I found that I'm super curious to try is a new device for postpartum hemorrhages. So postpartum hemorrhage, I had a terrible postpartum hemorrhage yesterday, actually. This woman lost like 4 liters in 20 minutes, and it was intense. And she was losing this blood as we were attempting to get a Bakri balloon in, which I think if you guys, if you haven't used one, it's essentially it's for uterine atony, which, you know, causes the vast majority of postpartum hemorrhages. And it is a tamponade balloon, similar to like a Foley balloon, but much, much bigger, can hold up to 500 cc's. And you insert it into the uterus and blow it up, and it sort of collapses those vessels that way. So this device is called the Jada System, and it is actually like a wound vac of sorts to collapse the uterus instead of to fill it up. And I have some pictures here. And so you can see it was it has had its first like clinical FDA approved trial, and had a 94% success rate, which, to compare that to the Bakri is a very high success rate too, like 87%. And the Bakri usually stays in for 12 to 24 hours. This stays in for 1 hour, and its effect was seen within 3 minutes. And I don't know if you guys can tell here, but the vacuum actually comes, you can almost get, I don't know, can you guys even see my mouse? I don't know if you can, but the vacuum is coming from inside that silicone ring, so that it doesn't collapse the vacuum as the uterine tissue sort of collapses on that. So I'm fascinated with this sucker. I think if we could crack the nut of postpartum hemorrhage, we will save so many lives, and it would just be so exciting. It's so exciting to me to see some of this that's coming out. Okay, there's also a bunch of interesting contraceptive options that are lurking in the ether, some closer to where you could see them than others. So there's Phexxi, which is a new and actually readily available now gel that can be inserted with an applicator into the vagina up to an hour before intercourse. And it changes the pH of the vagina, makes it acidic and so inhospitable to sperm. And it actually, the vagina is normally acidic. So it's the semen that's usually alkalinic. And so it's kind of just, neutralizing the alkalinicity of the semen. There's a once a month birth control pill that is in its first phases, that is not even first phases, I shouldn't say that, first even clinical trials that I think they just finished like pig trials or something, but we'll take a look at that. There's a vaginal ring like the Nuva ring that is good for a year. And then there's this really exciting blossoming field of male contraceptive options. So let's look at a couple of these. So female options, this one up in the right corner is the once a month birth control pill that's being developed. So this thing is a fascinating little guy. So it is, it's a micro pill and it's got this star shape and so it folds into this capsule that allows you, that's in this dissolvable gelatin. So you swallow it and then it springs itself open after that gelatin dissolves. And then these arms have polymers of estrogen and progesterone that are slowly time released. And its shape allows it to not pass by the pylorus. So it actually just sits in the stomach for a month as it all the way dissolves, where then it can pass. Like, how cool is that? I mean, kind of crazy and weird and definitely needs to be tested, but very cool. And then here's the ring that is good for a year. So you can actually control your fertility and your periods with this, because you can, remove it when you want to have a cycle and sort of time your cycles like you would with continuous cycling on birth control pills. So these male options are are super interesting and very sort of preclinical, but there's a male contraceptive gel that you put on your shoulder, and it actually has some GnRH blocking, so basically blocking FSH and LH, but then it's an add back of testosterone. So it's blocking the gamete production, but then adding back the testosterone so that you're not getting the side effects of, that's the big thing with male contraception, is like, how do you decrease the gametes but not lower the testosterone and therefore have, really bad side effects. And then there's a pill that's looking at, it's basically the same thing. It's just in a different formulation. And then there's these like reversible vasectomy kind of options. And so this one is a gel. So the procedure is done just like a no scalpel vasectomy, but the vas is simply injected with this polymer gel that is, I forget, I think it's like negatively charged and the semen are positively charged. When the semen hit it, they can't get through, but they also, it like ruptures their tail because of the, the charge of it. And then the semen are just absorbed, or not the semen, the sperm are just absorbed. And then it can last for 8 years. And then when you're done, or when you're ready to conceive, then I was just dying. It's like they go back in and then they just flush your tubes with it, just like a no scalpel vasectomy, and they flush the vas with baking soda and water. I don't know, guys. I'm just here to tell you what's going on, but and then
Stacy, can I ask 2 questions?
Yes, please.
So I thought marketing surveys always said that male contraceptives were going to fail because women would not trust the guy because the guy doesn't bear the outcome of pregnancy. So I thought that was one thing. And then the second thing is, in reading about Phexxi in the medical letter, they pretty much trashed it. They said only about 85% effective, which to me is in the realm of a lot of stuff that if a woman wants contraception, I don't see 85% as being really that useful. Could you
Totally. So I should have mentioned that. So 14 out of 100, I think, was the rate for failure with Phexxi, which is like on par with, actually not even quite as good as condoms. So Phexxi is being marketed more as an over-the-counter option to use in addition to other forms of birth control. And certainly for women that cannot have hormonal birth control, which, I have a lot of those patients. So I'm always really interested in other options for them, because you start to get very limited on what you can use. So, so Phexxi was almost seen as being, because Naloxone 9 was like that. So you guys probably remember when like that was spermicide was the thing, and you would put it on your, diaphragm or whatever, or, but then it was like breaking down the condoms, and actually it was very irritating to the vaginal mucosa. So Phexxi is kind of, I think, trying to be like that, but not irritating. It's made of, let's see, I have it here. Yeah. Lactic acid, citric acid, and potassium. So, it's, so not effective by itself. It's thought that it also provides lubrication. So I think it's trying to be this add-on, I would say. As far as male birth control, I think there's more interest than there used to be. The number of studies that are actually, so from 1990 to, so from 1990 on, there was, I think, like 8 studies, I can't find it in my notes here, looking at male birth control, and none of them got to an FDA level. And now there's 28 from 2004 to current, and 14 of them are in early stages of clinical, like of applying for clinical trials. So to me, that tells me they must be doing their homework, and there must be some sort of demand here. And, I think that, who knows, maybe with just more education, and then also changes with, some of the legal ramifications of fathering a child and the financial expectations and just different pressures, maybe that is turning a bit of a corner to try and empower men to take some of the ownership and control of that. 40% of pregnancies in our country are unintended. So I'm all for like the women still not trusting the men, and the men doing something and the women still doing something. I think that would be good for all of us. Okay, so last thing on this is this on-demand sperm switch. It's a size of a gummy bear implanted in the scrotum. The vase is connected to it, and it's like literally what it looks like. It's like a sperm switch. Now, I have no idea, like, I just don't even know what to say about that. It seems quite invasive. And then the other thing is, I'm like, so is it like, I'm ready, like today I want to, possibly get pregnant, but I don't know. I just had lots of mindset about what that could be for, but very interesting. I mean, got to give it to people for being creative. Okay, and then lastly, I just wanted to end with, and I'll give you guys these slides so you can go into these pages, but the way that I stay appearing as though I'm up to date, I should say, and the way I have a little piece that I'm like not totally out of the loop, because I got 3 little kids. My plate's full right now, so I'm not sitting and reading a lot, not nearly as much as I'd like to, but I've kind of developed some hacks where by just doing these things, I sort of always a little bit know what people are talking about. So choosing wisely, I like I mentioned, this site called Practice Update is kind of nice. And the reason I like it is because you can pick exactly what you want, all the way down to like hematology, and you can get just monthly quick hits. So you can get monthly top 10s in whatever choices you make. So I like that, because I cannot handle getting spammed every day from like Medscape and all the ones that like give you too much. I think I was like an eager beaver at one point and like signed up for those things. And I still feel like I'm like figuring out how to turn them all off at times in my email. So I like the monthly updates. And then the OBG project is really cool, grassroots, that started on social media, that now has an app that is very, I'll show you guys real quick here. I like they just present things in a way that is really easy to dig into things. They have great like commentary on breaking things down for you. And oh goodness. Trying to accept the cookies. Yeah, so it's just, and it's like quick hits, and you get like, I think I get a weekly email from them, but I think you can adjust those settings. So if you do OB and office-based gyne, I definitely recommend them a lot. I think that they're similar to this next one, which is primary care wrap. I don't know if you guys have heard of primary care wrap, but if you haven't, this is a must. It's CME, it costs some money. You get half off if you're military though. So make sure you tell them you're military, but you have to email them. Like, I mean, you have to like directly talk to them. It's not like on their website. But primary care wrap is awesome. Once a month, like keep you in the know, funny. They're like a joy to listen to. They're so funny. It's like very like hip, current family medicine. So love that. And then the other thing is every once in a while, it's usually when I'm updating my up-to-date CME. So, you know, it like collects for you and then you have to go in and like do all this stuff to it. That's when I'll do a what's new search. So what's new in family medicine, what's new in obstetrics, what's new gives you review articles that are done, or like a review. It's like a year in review that UpToDate does that'll give you quick hits, very similar to like what I did today. So just very boom, 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 boom. And so that's a great way, like kind of, you know, once, twice a year to just do a quick search and be like, oh, okay, you know. And then also if you have favorite journals, most journals will have a most popular articles of in the year. So I do that with the Green Journal a lot. The Green Journal is the OBGYN journal that I cannot keep up with. And some of it is so in the weeds that I need like what was important part, you know? So yeah, so there's just some, oh yeah, here's some stuff about primary care wrap. If there's one thing you're going to check out primary care wrap. I just love primary care wrap. I just listen on the fly whenever I can. And they're funny and they're real and it's amazing. They'll say something and I literally that day in clinic, it will like come into play. It's just super practical. Okay, so hopefully we hit our topics here of just kind of a quick overview of some of the key changes, looking at affordability and then exploring ways to kind of stay in the loop, which is hard to do. I'm happy to take questions and yeah, I appreciate the opportunity to be here with you guys.
Thank you, Stacy. Anyone have any last minute questions? If you don't, I just wanted to, I guess, make a comment or maybe, I don't know, question. I don't do OB, but I wanted to see if you had any thoughts or any updates on, you know, the high maternal mortality and morbidity among like African-American women. That has been like, you know, hot in the news. And I don't know if COVID has uncovered more of that or have added to that, or if there has been any new things that came out from that.
Yeah, that's such a good point, Winnie. And I think, you know, I don't think it's new, which is sad. I think it's probably always been right in our face. And I think that COVID and then some of the just, you know, social examination that's been occurring in this last, you know, year and a half has shown a light on it. And it is definitely something that we're discussing and kind of grappling with here because, you know, my department here is fantastic and we really pride ourselves on providing this like, you know, amazing care, and we have really excellent like numbers, but our numbers show it too. And so we did have a meeting where we kind of like looked at it, and it's really kind of hard to get your head around it because I don't think we understand why it's there. And I don't think there's a unifying diagnosis of why it's there. I think it's something that's going to be multifactorial and complicated to untease. So I think super important. I think it's definitely something we got to figure out. I think that same pattern could probably be seen across the board, not just in obstetrics or maternal health. I think we're seeing that with vaccination rates. I think we see that with cardiovascular outcomes. I think there's so much involved. So yeah, more work to do, but I don't have any answers, but definitely important to bring up.
Thank you. Well, thank you for your talk today. It was very interesting and definitely good things to know and stay up to date on. So we appreciate you. If there is no more questions, please make sure that you guys do evaluations. And we will have the recording for you next time. Our next round is going to be on June the 9th. So look out for an email coming from me on that. With that, I'll say thank you, Stacy, and have a great rest of your day and your week.
Thanks, guys. Take care.